Hey everyone, welcome to an evening edition, especially if you're on the East Coast of VMR. My name is Jazz. I'm actually coming back to the discussant seat after a very long time. So I'm excited to do it alongside Robbie. Just been busy with being a father and just trying to balance work and home life. So I'm excited to kind of finally get back into the discussion. And Robbie, I'll pass it to you for you to say hello.
Oh, thanks, Jas. When Jas reached out, he's like, "Can I do a VMR session, but it'll have to be late at night?" I was like, "Absolutely. We haven't had you on for a while, so can't miss not having you." So a late night edition it is tonight, and along with us, I'm glad to see we have some support. We have first Sarah. Sarah's going to do teaching points. Sarah, if you want to unmute and just say hello.
Hey, I'm really happy to be here doing teaching points tonight, calling in from Atlanta, Georgia.
Awesome. Also East Coast time, so 8 p.m. And then we also have Manaswini, who's doing scribing. How are you today?
Hello everyone. I'm doing scribing today. I'm doing great. Excited for the case and the discussion. Uh, Always look forward to Dr. Ravi and Dr. Jazz being here. And I'm from calling in from India. It's early in the morning, 6:30 a.m.
Oh wow. Okay, so somebody's international. We were talking about who's probably going to be up, and certainly all the people in Europe are probably fast asleep. And we have the fabulous and one and only Aaron, who's back to present another case. How are you, my friend?
Good, good. Yeah, I'm ready to present another case and hopefully you guys enjoy this one.
Awesome. And let's get going. Deploy the whiteboard and first aliquot. Jas, you have first dibs of the opening aliquot.
All right, so for the first aliquot is going to be the one-liner. It's a 35-year-old male coming in for hearing loss.
Awesome. All right. So I think the first thing that grabbed my attention, or the chief complaint, is the patient's age. Hearing loss, usually, it's common in the elderly. You get your, sensory neural hearing loss. Usually, when it comes to like certain frequencies, that's common in the elderly. But this is a 35-year-old gentleman that's presenting with hearing loss. The other thing I would want to clarify, is it unilateral or is it bilateral, hearing loss? I think that's one of the things that I would kind of like first want to specify. And then second course is time. Was it sudden? Was this hours and days? Or was this gradual, meaning months to years? So I think that will really shift my needle of how I'm going to be thinking about hearing loss here. And then, like I said earlier, is this conductive versus sensorineural versus mixed? I think if I'm thinking of the time course of acute, so less than, let's say, a few days, this is I would be concerned more of like an urgent issue, something that might need like a rapid ENT evaluation, maybe some CT scans, and maybe even questionably thinking about steroids. And where I'm getting at is, a possible manifestation of giant cell arteritis. So, but again, then the next line of thinking I have is unilateral versus bilateral. Bilateral would make me concerned of a systemic process, especially when it's acute. So I would be thinking about ototoxicity either from a medication. I would be thinking about a systemic autoimmune or infection. And then if it's unilateral, the list goes even longer. It could be something wrong with the ear. It could be whether it's, something like most common thing is just an impacted cerumen. Can actually, if it's not hearing loss, definitely muffled hearing in that side. But especially if he's been having headaches or other symptoms, an acoustic neuroma, Meniere's disease, and even recurrent ear infections can also do this as well. And then, I also want to ask the patient, are they having any other symptoms in addition to the hearing loss? Meaning, are they having an imbalance or vertigo? Are they having any ear pain? Have they noticed a rash behind the ear? And are there any other neurological symptoms, facial weakness, diplopia, numbness, any ringing in the ears. And then I think from there, I'll probably have a further differential. I don't want to like say too much over just the one liner. I think the differential is pretty broad, but to summarize, the first like the first sentence is just: is it acute versus chronic? Is it unilateral versus bilateral? And is this hinting towards conductive or sensor neural hearing loss? Based off the patient's age, I would probably say it's most likely sensor neural. Ravi?
Wonderful start, Jas. I'm really impressed. You pretty much laid down the framework for approach to hearing loss. Now, what was interesting, if you take the age, so I will pretty much hang on to ride your coattails with conductive hearing loss and sensory neural hearing loss. So you asked, is it duration of the hearing loss? Is it unilateral, bilateral? Is it fluctuating? Is it progressive? Age wise, I think usually maybe younger people may have more conductive and elderly patients may have more sensory neural hearing loss, but it's not cemented, it's not firm. But if you think or imagine an ear, and from the outside inwards from the canal, where could an issue be? If we just kind of take out of the picture bilateral, unilateral. So from the outer ear, any foreign body obstruction you might see in pediatric cases. I remember in peds, we always be removing things from the ear. It could be toys or little Legos or things like this. I think in an elderly patient, once in an ENT rotation, we removed a cockroach from a patient's ear. So also things could find a warm, fuzzy place to crawl into and cause conductive hearing loss. How about the inner ear? And as you move in towards the ear, you are taking sound and then transmitting it to the middle ear, where you have the tympanic membrane, you have fluid, and so on. And it is still a mechanical process where the sound comes through. It's still going through the mechanical part of the ear. So middle ear issues, you could have otitis media is common, right? So infection could cause it, or even if the tympanic membrane, again, unilateral, could be perforated. Now, if you move into the sensory neural area, now you get into the neurologic causes. So here you might have things like labyrinthitis, you could have internal auditory artery, infarct, could be schwannoma or any kind of malignancy, anything compressing the nerve. It could also be infection. So infections could also do this as well. There are many other kind of causes, but at this point, are we dealing with some part of the external ear, middle ear, or is it the inner ear? And again, unilateral, bilateral, there's some conditions which can be unilateral and some that could be bilateral. We'll have to see. The medications is interesting, what you mentioned. That definitely would be bilateral. So I'm pretty much following your framework that you've mentioned there, Jas, and we'll see what the next aliquot shows us.
All right. That was a great discussion. You guys were able to say so much about just my one-liner of hearing loss. But to give you guys some more history, so 1 year prior, this patient noted gradual onset of bilateral hearing loss, with the right side being more affected than the left side. And this was associated with tinnitus on the bilateral ears. This was not associated with any headache, dizziness, loss of balance, or any other neurological symptoms. And I'll stop there.
All right, so the questions that we had, so it is gradual duration and then bilateral. So this isn't something that suddenly happened like trauma. Trauma could be acute, it can be impactful. This is something that has been gradually building up. So what kind of things do you think about if we take about the two spaces that Jas had mentioned, conductive and sensory and neural? I would think conductive less. It would be something that could actually impact one side, but it would be something within the ear canal, like cerumen. We may see that in somebody much older, or otitis externa. But you have bilateral hearing loss, which has been gradually occurring. So you want to think about something that is impacting within the brain, maybe, along the neural pathways that allow the mechanical sound to be converted to neuroelectric signals, and those signals are then conducted to the brain. So somewhere along that path, and whatever nerves may be involved, which could be cranial nerve 8, that is impacted by something. And this can happen over a period of time. Could it be something growing and slowly emitting pressure onto cranial nerve 8? Could it be something within the brain itself? If you thought about something like I mentioned infarct, that kind of would be acute or sudden. So I'm thinking more something along the lines of maybe something that's growing, maybe impacting cranial nerve 8, causing this bilateral hearing loss, and something gradual that's occurring. Infections. I mean, what kind of infections do we think about? Viral, maybe bacterial. Syphilis could be insidious. And also we could think about Lyme disease in this case, but yeah, I would kind of have to ponder over those two. But the other kind of infections, common viral infections that cause labyrinthitis, things like that, I think that wouldn't occur for this long, especially 1 year onset of bilateral hearing loss. I just want to ask Aaron, has this been the hearing loss was 1 year ago? Is it getting worse over the past year, or is it like a little bit of hearing loss, tinnitus, and then it suddenly got worse?
Yeah, it's been gradually getting worse.
Jas, over to you.
That was great, Robbie. I don't think I have like too much to add. I think, I think the one way to summarize the second LQUAD is this is chronic, progressive, bilateral, likely sensory nerve hearing loss. And when I think about that, I was thinking, okay, this is teetering towards inner ear / cochlear pathology. The lack of pain or otorrhea or fevers, I find the fact that ROS being completely negative makes me feel like a systemic disease is less likely at this point in time. Now, obviously, any systemic, like for example, an autoimmune condition can always have initial manifestations that might be isolated to one area before it gets more progressive. But what are the chances of it happening bilaterally, right? The other thing we should also consider, especially with the tinnitus, is an acoustic neuroma, which can happen bilaterally. It usually starts off with unilateral, and I think Iran mentioned that one side was worse than the other. But one thing I just want to clarify, and it may not be as sexy as some of the diagnoses that are mentioned in the chat and etc., but I would love to know what this patient does for occupation, or even recreationally. Does this patient play in a music band? Or do they work in an environment that has construction and loud noises? Do they use firearms and hunt for fun? Because noise-induced sensory nerve hearing loss could be gradual, could be in this particular pattern, it could be the most likely diagnosis here. But I think that's where past medical history, meds, and then a detailed social history would be very key here. And then I think, the fact that the patient doesn't have vertigo would make me steer away from Meniere's disease, but it's not always possible. It could still be possible. But that's all I have to add. I think, I'm very excited to see what the next aliquot. So exactly. Do they enjoy raves? Thanks, Valet. So I'm curious to see what the next aliquot tells us.
Yeah, just that's interesting. Yeah, noise trauma, which is true, right? So heavy metal concerts, raves, like you mentioned. The other thing that came to mind when I'm teaching, students about meningitis is strep pneumococcal meningitis. Usually, we give steroids because it has a tendency to cause hearing loss. So, say in this patient's history, if there was previous meningitis, this could be a sequelae of pneumococcal meningitis or other meningitis that could impact cranial nerve 8. But back to Aaron for the next aliquot.
All right, wonderful discussion, guys. So for the next aliquots, just more history. 11 months prior to this, he sought consult at another institution and was reportedly given unrecalled antibiotic otic drops, which he said didn't help him with much. He also had a hearing test done. This was unclear if it was like pure tone audiometry or anything, but he states that he had it done and he showed it to the doctors at the other institution, and it did confirm he had hearing loss, quote unquote, but we're not sure at this point if it was sensory neural or conductive. And yeah, he didn't have any imaging done or anything at that time. And then 10 months prior, the patient reported, quote unquote, complete hearing loss from both ears. At this point, he'd had to communicate with writing to, yeah, he had to just write. Or, well, he could speak, but like we would have to write because he wasn't able to hear anything.
Ryan, do you mind giving us just like the past medical history, meds, and social history, if that's okay?
Sure, sure. So for his past medical history, actually, he has a history of GI tuberculosis, status post XLAP, with an ileocecal resection and ileocolostomy that was done a year prior. He completed 6 months of TB meds. So he's done with that. For family history is just hypertension, diabetes, and then, yeah, he's not currently on any meds, but that's his relevant history. Do you want his social history as well? Okay, so for his social history, he's actually a previous 2-pack-year smoker with occasional alcohol, no illicit drug use, and he is, for his occupation, he's a non-uniform personnel at police headquarters.
Okay, awesome. So this was pretty interesting. I don't know if you feel the same way, Robbie, but the I don't know. I hopefully I didn't mess up Iran's presentation, but he was holding us the past medical history. But before I jump into that, we get that this patient was told that he had a hearing test done, which I would assume in this case is an audiometry test, which either showed conductive or hearing loss. So he definitely had something, and then basically a month later got complete on hearing loss in both ears. And then we found out that he had history of GI tuberculosis, and completed 6 months of treatment. The no response to otic antibiotic drops just tells me that this is less likely to be like a ear infection, like an externa, otitis externa. I think it's reasonable to assume that the audiogram documented like sensory neural hearing loss, until we get further data. I think with this rapidly progressive bilateral hearing loss in a 35-year-old gentleman, I think you have to kind of consider ototoxicity here. So I would be very curious to see what medications they were given for TB treatment. For example, were they given aminoglycosides or something like that? They're very potent to be causing hair cell toxicity. I would like to know more about what they were treated with. I think patient that got TB at a young age, and especially if they were like at an endemic region, I also want to now then start, consider, especially the rapidly progressive hearing loss. Is there like a autoimmune condition that we need to now consider? And it seems like the social history kind of rules out any recreational or occupational noise-induced hearing loss. I mean, it seems like he's a non-uniform police officer. I don't know how often they do firearm training, but there are sirens, and their job may expose them to some sounds. But I still would not fit the rapidly progressive. This would be more gradual. It seems like in a month he went from noticing that he's having hearing loss to completely not even hearing at all, to the point he's writing things down. I think the last category I'll mention before I give it to Ravi is that infections. Like, he had history of TB, and if he did not complete treatment properly or it was resistant, could this now be TB meningitis presenting? as bilateral neurocentral hearing loss. So those are things I'm thinking about. Ravi, what would you like to?
Absolutely. I think there's a lot of rich attributes here of the history and family history and also medications. So if we start picking apart the past medical history, diabetes itself, right? It has a predilection for vascular disease. At 35 years of age, it could well be that this could be hearing loss due to diabetes. So that is one point there. Second point, high blood pressure. Combine diabetes with high blood pressure, the vessels are at risk or are at jeopardy for various conditions. So ischemia, infarction of various nerves, the brain. So could this be a vasculopathy or vascular disease of the auditory system, the brain itself? What else could you have of the vessels? Vasculitis. You mentioned autoimmune disease, so vasculitis could be at play too. Could this be, if we start thinking in buckets, autoimmune could be there. Medications very much. Medications pretty much probably takes the cake here with being very likely, like you had mentioned in the first aliquot, bilateral, something that could be gradual, TB drugs, yes. Or it could be TB itself. I think like 2 weeks ago, Aaron, or a week ago, gave us a case where there was TB. And we were like, oh, yeah, this is probably TB because TB can go anywhere. It can mimic many kinds of things. It can cause pseudotumors. It can press. It could infiltrate. It could cause devastating disease. And like you mentioned, a very, very important component of TB has a predilection for the base of the brain, and where you have the base of the brain and where the cranial nerves exit out, any of those nerves could be fair game for pathology. So cranial nerve 7, 8 could be manifested as such as this patient here. But I would look for more or groupings of cranial nerve diseases together. But then again, I haven't seen a case like that before. So it could be like one nerve, two nerves, or a couple of nerves being impacted at the exit points at the base of the brain. So definitely imaging. If we we kind of have hypothesized, we've put out a lot of different things. I think testing, starting first with physical exams. So sometimes we jump the gun and we want imaging, we want labs. But I think it'll be really rich to see what the exam has, and then we use hypothesis-directed physical exam in this case. So what kind of let's spend a few minutes and think about what exam would really help us, maybe give us the diagnosis here. Is there an exam or maybe a technique that will really help us? I know Yasmin mentioned that she wants the syphilis serology. Yes, of course. Anything comes to mind? I guess Vale had mentioned earlier doing the Rene and Weber test, which will be very, yep. Hans also mentions that. Anything else? I guess the full cranial nerve examination would be helpful as well. And the full neuro exam. Anything else? I guess dermatologic, so skin, maybe look for external signals of maybe autoimmune disease or infectious disease. Audiometry with bone and air conduction, very good, Yasmin. Yeah, so a couple of those things, those maneuvers or those tests will be very helpful in this case. There's no dizziness, so I don't think we're dealing with anything to do with the balance centers here, so we don't have to do anything like HINTS test or anything like that, but I think these tests I'll be very interested in. All right, I don't want to spend more time, but I'll swing the mic back over to Aaron.
Yeah, great thoughts, guys. I just have a little bit more history for you guys, and then I'll give you the exam in the next aliquot. But for this aliquot, since you guys were thinking about that, we also took a step back and we were like, this time frame is a bit weird. Just to start with hearing loss, you were like, have you had any symptoms like before this? Like, what's like the earliest thing you can remember? Like, you know. And he said, oh yeah, I think 2 years ago, he said he had an upper respiratory tract like illness associated with like green foul smelling discharge from his right ear. He took Tylenol without improvement, and he finally sought care after a week. At that time, he was also given unrecalled otic antibiotic drops without relief, actually with relief of symptoms, sorry. And after the resolution of that infection, he did start reporting a decreased hearing from the right side of his ear. So yeah, I'll stop there and just would like to hear what you guys, how this info changes your train of thought.
I guess I guess I go. I forgot who was going first, but is it me? Yeah. All right. So I caught a bit of what seems like he probably had an infection in that ear with discharge and one side, right, Aaron?
Yep, at that
Yeah,
time it
and
was
it
only
was the right side. Okay, and he started having hearing loss and was prescribed antibiotics. So my first question would be, was there any response to antibiotics at that time?
yeah, he did improve afterward.
Okay, so it was assumed at that point there was some infection. We'd mentioned earlier on, again, revisiting this framework that Jas had just beautifully laid out. So conductive and sensory neural. And what I'm sort of determining from this bit of information that you've given us is that now seems like there may be a mixture of conductive and sensory neural. And if we just visit the conductive portion of the hearing loss framework, you tend to have infections like otitis externa, and you could have other viral infections that could manifest in the ear. And with antibiotics, it seemed to have resolved here. So most likely a bacterial infection, and the hearing did improve. How can we relate that to what's happening now? It doesn't seem like an infection would have just lasted for a year. Usually infections would manifest in complications, whether it be pockets of purulence like a pus, abscess, or it would penetrate into the neighboring areas such as bone and cause osteomyelitis of the bones, the neighboring bones, the skull, and so on. At this point, yeah, I don't know. Could this be a sort of long-term insidious infection that kind of lasted? It got better, but then, yeah, it's kind of difficult to try and relate it to this. Could it have come back? I mean, he is immunocompromised, the patient. If you think about his immune status, he's diabetic. So that puts him in step one. We always mention pseudomonas ear infections in this case. But there are many other causes, strep can cause, and so on, otitis externa. So at this point, I think he had an episode. Could this just mean he has recurrent episodes? Could he have another kind of a immunocompromise or immunodeficiency like IgA deficiency, CVID, and so on, where he gets recurrent infections? So you told us one infection and then this one impactful one where both ears are impacted. What do you think, Jas, at this point?
Yeah, Ravi, that was pretty great, and like exactly what I was kind of thinking of along the lines of as well. I think this is a really great case because it's applicable to what we deal with in real life. We get like this storming of data, and we have to now figure out if this data is connected to his current complaint or not. How do I explain that this guy had likely some type of otitis media with probably with tympanic membrane perforation that led to this otorrhea? How can we connect that to his bilateral progressive sensory hearing loss? And to be honest with you, it could be true and true unrelated. And this is just a data point we may have to put aside and not really explain why he's having bilateral progressive sensory hearing loss. But one way that I can potentially connect it is like think back to when's the last time as an adult you had an ear infection. I can't think of anything on top of my mind. Like last time I had an ear infection, I was like, probably 12 years old. So, it's not common. So then does he have an underlying vascular problem such as granulomatosis polyangiitis that put him at risk for that ear infection 2 years ago? And now this is progressive, and now it's becoming bilateral sensory hearing loss. That's the only way I can connect it. But I also want to pause myself and say, what are the odds of this guy having GPA and NGITB? So I think what I would do is clarify the history of when he got the 6 months of treatment. Was it with either aminoglycosides or streptomycin, et cetera, and does it correlate with his symptoms? For example, if this gentleman got GI-TB treatment like 20 years ago, probably not moot point. But if it was 2 years ago or a year ago, I think that's when I would get a little bit more suspicious of common things being common. So I think we need more history in terms of what was the treatment he got for his TB. And then at the same time, like, is this all interconnected, or is this just a swarm of data that we now have to maybe put away aside what he had 2 years ago that likely just felt like it was probably just a otitis media with the tympanic membrane perforation? Oh, Aaron's TB meds were 1 year before presentation. Patient also unsure which meds he was given. Okay, yeah, so I would still try to dig into the patient's chart, call his previous physicians, try to find out what medications he was on. But the 1 year before presentation is concerning still from ototoxicity from his medications. And I would say for now, I would put the 2-year infection that he had aside, exactly like you said, Robbie. We don't know if it's connected or not.
Yeah, just
Aaron, I'm excited. Oh, sorry.
just one correction. Unfortunately, the diabetes information was moved over. It was in the past medical history. I thought it was relevant to him, but his family history. So the diabetes, he could have diabetes, and that could explain recurrent infections. Two things I forgot to mention. This might be the right time because we're at this second aliquot juncture, but the ileostomy, and if you think about it, what does an ileostomy do? Could that cause electrolyte deficiencies? Could that relate to hearing? I don't think so, but it could happen. I guess if you research, there might be a paper out there showing correlation to electrolyte deficiency and ileostomy. Smoking as well could have some relevance. Again, vascular injury, but at this point, diabetes not confirmed. High blood pressure as well. And there's some alcohol use as well. And that can have potential neurotoxicity. Just to close up this second aliquot and then move on to the third. So let's do this. We're kind of at the half-hour mark. If we get the exam, why don't we have fun? We have quite a few people. We can do breakout rooms. Over to you, Aaron.
All right, so here's the physical exam. So for his vitals, everything was stable. BP was 110/80, heart rate was 61, RR of 20, temperature was 37.5, and he was saturating 99% on room air. For most of the exam was normal. So the cardiac, lungs, abdomen, extremities were all normal. And now for the HEENT part. So I'm going to do the ears last. So yeah, for his nose, it was a midline septum. The nostrils were patent, non-hyperemic, non-congested turbinates. For his throat, the uvula was midline, non-hyperemic, non-edematous, posterior pharyngeal wall with grade 1 tonsils. And his neck was supple without any cervical lymphadenopathies. And for his ear exam, so for his right ear, there were no gross deformities externally. And then inside, there was a total perforation of the tympanic membrane with granulation tissue without any active discharge. On the left ear, there were no gross deformities externally. It was sclerotic inside, and there was no active discharge. But so for his neuro exam, we did a Weber and Rene test, of course. So the Weber test localized to the right side, with the Rene test on the right. The right-sided Rene test was bone conduction greater than air conduction, while on the left, it was air conduction greater than bone conduction. And his neurologic exam was otherwise unremarkable. The cranial nerves were all unremarkable, aside from the cranial nerve exam.
All right, wonderful, Aaron. Thank you. Very well presented, very organized case. I think let's stop here and do breakout rooms for 3-4 minutes. All right, welcome back, everybody. Hope you all had a very interesting breakout room session, and we stopped at the physical exam. Should we have anybody want to unmute their mic and maybe share with us what they had learned in the breakout room? I'd popped into, who was there? Yasmin, Vale. Or any other room. Or if not, Jas, what do you think?
To be honest, I think we had a really good discussion. I don't want to speak for them, but Hans or Sarah, if you want to kind of chime in on what you guys were talking about. If that's okay, I can go too.
Yeah.
Hans says we are far from a diagnosis.
I think Sarah's going to unmute and share her thoughts.
Yeah, I think the basic summary of the Weber and Rin tests was that they point to two different things going on. And I think that that's consistent with also the external exam, that we have like one perforated membrane and one normal. And then the fact that we still don't know what treatment he got for his tuberculosis is still a piece of information that was rubbing us the wrong way. So we hope that there was a way to interrogate that from his medical record or some other means.
Yeah, that's what I thought. Jas, I think I'm going to share what I thought about this test. So the right ear is really where all the pathology is, right? So you got the perforation there. And when you have with the Rene test, the bone conduction greater than air, so that means there's a conductive hearing loss on that side. So the right side is abnormal, left side air greater than bone, normal. And when we did the Weber test, it lateralized to the right side, and that is if it lateralizes to the bad ear, then it's conductive hearing loss. If it lateralized to the good ear, which was the left side, that would be sensory and neural. So everything's pointing to the right side where you have conductive hearing loss. So this doesn't fit the pattern. This is probably a red herring. So it really doesn't move the needle for us as we had thought about hypothesis-driven physical exam in this case. So I think we need to dig deeper and maybe go with imaging. What do you think at this point?
Yeah, no, I agree. So the way we talked about in our group was the fact that the right ear, I agree with exactly what you said. It's conduction hearing loss. That's the easy one. Patient doesn't even have a tympanic membrane. It's perforated. So that's what lateralizes there. The left ear, the Weber test suggested left-sided hearing loss because it didn't lateralize to it. And then on top of that, remember, Rene test cannot distinguish from normal and sensory hearing loss. So the fact that, the left ear could either be normal pattern or sensory hearing loss, but we know that this patient can't hear in both of his ears. So I think this is a bilateral sensory hearing loss. The fact that he has conduction hearing loss on the right is probably from the complication from the infection he had 2 years ago that led to maybe some sclerosis of the cochlear anatomy. But there was probably an underlying ototoxicity that was leading to the sensory hearing loss. That's the one thing that we can conclude to, but this is a very complex exam, and neurology frightens me. So I think I still stand by like what we said previously, is this might be two different processes, and that the thing that led to his rapidly progressive hearing loss is still out for debate. And
Right.
unless you have something else to add, I would love to know what more. Actually, Ravi, let me ask you this: do you think his labs are going to be completely normal, or do you think they'll be abnormal?
Probably normal.
Yeah,
I'm not getting that sense of anticipation of infection. We talked about electrolyte depletion with the ileostomy, but I'm not getting any sense of that in the history. So anticipation can be very powerful. I really want to go for imaging here. The left ear exam was interesting. There's granulation tissue. It's just the tympanic membrane's trying to heal, so you're getting all sorts of growth happening in that area. Remember histology when we looked at the tympanic membrane, all those wonderful layers and different cells and so on. So I'm trying to recall that, but probably the granulation tissue is just a remnant of healing that's trying to happen. Okay, back to Aaron for let's see the lab.
All right. So for the labs, I'm not even going to give you guys the values, but basically the CBC was normal. There was just the WBCs of 10.5, if that interests anyone, but otherwise his creatinine was normal, BUN was normal, and his electrolytes were normal. He had a chest X-ray done that was normal, and one thing we did was a pure tone audiometry, which was consistent with conductive hearing loss on both sides. So I'll leave you guys with that.
Very interesting. The audiometry is not going with the Rene test here. So this is very awkward, this case here. It's not fitting. But you know what? I think with the complexity, bilateral hearing loss, and with anticipating sensory neural issues here, yeah, it's probably these other testing. The peripheral testings is kind of not going to be very good in this case. I think it's going to with the right ear issues and so on. It's not going to be exact. I think probably imaging will be key here.
You know, my luck would say that the first time I would discuss a case since Van back is freaking neuro. I'm not playing lottery this week, I'll tell you that much for sure. This is I was not expecting bilateral conductive hearing loss here. So I'm gonna have to like take a step back and just kind of say, okay, so we know that the right side, that makes sense. The left side is now showing conductive hearing loss. So this goes less theory now with the ototoxicity. So that seems very unlikely now. So now the fact that patient doesn't know his TB medications, maybe I can give him a break and like not go down that route anymore. The right side diagnosis seems a little bit more straightforward. Seems like he had chronic suppurative otitis media with tympanic perforation, and the granulation tissue could be from the healing. Now, why is the left ear showing conductive hearing loss despite grossly looking fine? And you know, could this be something that is going further down, like to like a middle ear effusion? But the exam didn't show that. I wonder now about a bilateral cholesteatoma, and those are really hard to diagnose. So usually you need like an experienced ENT to look, but those are really rare, like bilateral. So given the fact the patient's history of TB, this is just me speculating. I have no confidence in this, but can this be like a infiltration of TB into his ear canal, leading to a conductive hearing loss? And that granulation tissue, was it really a granuloma from TB? And now that led to the infection. The granulomatous infiltration led to the infection, and they got secondarily infected with bacteria. That got better with antibiotics, but the underlying infiltration from TB didn't. And I don't know if how good the penetration of the TB treatment is all the way to the ear, and did it just relapse, or did it just not completely get treated and now it's infecting both ears? The timeline, I guess, would fit. The only other thought I'm thinking of is like bilateral osteosclerosis, but why does he have it on both sides? One side makes sense where he had the infection. So I'm like pretty puzzled right now, but I'm excited to learn.
Yeah, I'm just going to add on to your wonderful discussion. It could be two things going on at the same time. So on one side is the perforated tympanic membrane. On the right side and left side could be middle ear issues, like you had mentioned. There could be a cholesteatoma, if I can pronounce it properly, or otosclerosis. So there could be two diagnoses that are happening here. TB, it's kind of odd. I would look for the patient, TB would drag this patient down, would have other complaints, pressure in the head, headache, and so on. Like, it would be kind of odd if it was TB, but you can never say never. But I'll swing the mic back to Aaron for the next dialogue.
All right. So I'm going to share my screen so you guys can see the imaging we did. Hold on one sec. Can you guys see my screen?
Yes.
Okay. I'm going to play it now. And I'm just going to play it one more time.
Are you able to go back a little bit just first? Actually,
Yeah.
even pause it right there. I don't
So,
know.
yeah, right there
right there,
on
right there.
the left, you see the bone there. You see the it's not homogeneous. There's material in there, maybe air, maybe, I don't know, sequestration of bone. But it's very odd if you look at it, right? So it's very difficult going through it very quickly, but that caught my eye. Is that the same thing you're looking at, Jess?
Yeah, it looks kind of brittle or like kind of like woven or just kind of destroyed. That's my non-medical.
Right there, right. Stop.
Yeah,
Right
right
there.
there, right
Right
there.
there.
Yeah,
Right there.
right there.
Right there. Oh, go back. Yeah, right there. So if you
Right
compare
there.
it to the other side, it looks like it's been compromised. So remember we initially were thinking about infection, chronic infections. Where do infections in the ear go? They're right next door to brain. They're also vessels. They can then burrow into the brain. They could also go into the bone. So it looks like this could be a chronic osteomyelitis of that area.
And Robbie, just a question: do you think the one on that left side looks a little bit mosaic to you, or no?
Yeah, it is kind of weird, right? It's not homogeneous.
Right.
The other side really does stand out, and it's almost like got pockets and pockets that are containing maybe infected material. Interesting, the labs weren't super exciting, but a white count might not be because it's holed up in this area. This area may not be open to the immune response. I guess once you start fiddling with it, it could open up. It's like opening up a can of worms, and you will get the leukocytosis, fever, and so on. Was there a SED rate or CRP in this case done? They're kind of non-specific, but sometimes can give you a signal to inflammation. Aaron?
Oh, sorry. No, there was no ESR CRP done for this patient.
So the question is like, what do we do with this? Is this, I guess ENT would need to come in and look at this. And is this an area that you take some material of and take a look at what's going on? I guess we'll have Aaron tell us the CT report. Yeah, we'll see if it's
sure.
report. Yeah.
Hold on. So I'm going to give you guys the findings first. So for the right side, the EAC was patent with an interval decrease of soft tissue signals in the EAC. The tympanic membrane was not well visualized, likely perforated or retracted. Mastoid air cells are fluid filled with sclerosis and erosive changes. And then the middle ear cavity / ossicles, soft tissue density is seen occupying the middle ear cavity with non-visualization of the ossicles, likely eroded. The scutum and tegmen tympani demonstrate erosive changes. And for the left side, The EAC's pain TMs are not well visualized, likely perforated or retracted. Mastoid air cells are fluid filled. Middle ear cavity, soft tissue density is again seen occupying the middle ear cavity. The scutum appears sharp. The tegmen tympani shows suggestive dehiscence. The ossicles, however, on the left are normal alignment, no erosions. And yeah, before I give you guys the impression of that scan, do you guys want to say anything about those findings?
So at this point, if we collect everything we sort of put together, we did think about, remember Jas, so stepping back to that initial infection, could this just be a sequela of that initial infection? And it can explain the conductive, right? So I was kind of downplaying the audiometry testing. So you re-emphasized it and gave it importance. So I reconsidered that. Okay, maybe that is indicating, yes, one side there's perforation, the other side there's the infection that could be holed up in that area. If we also revisit the TB, right? What if TB is holed up in that area? Could be another plausible hypothesis. And then the cholesteatoma, although I don't know the morphology on imaging, could that also be another consideration? So 3 things that we can sort of think about. Are there any pattern that we can recognize here for any of these pathologies? I'm not quite sure. But something that's long, sort of over a period of time, 1 year, not really raising its head, coming to a climax and causing great deal of problems, just slowly, steadily, behind the scenes, not being unmasked, and suddenly bilateral hearing loss.
Yeah, I this is like
Mhm.
probably one of the hardest cases I've discussed, and Aaron, you're presenting it flawlessly. So you're doing a great job. I wish I was smart enough to dissect it more fluidly. But Ravi, I agree. I'm like stumped. The only thing that I've seen like the granulation tissue, the perforation, the otorrhea. I wonder if he had right-sided cholesteatoma that just got missed, and now the left side developed and gradually gotten worse to the point where now he has bilateral conductive hearing loss. But I'm pausing at that because bilateral cholesteatomas are rare. So unless this is the rare cause of bilateral cholesteatoma, but other than that, I have no other things to add.
I think we've compiled a very good competitive list there. So let's send it back to Iran for, I guess, the diagnosis.
Yeah, so I was actually on the ENT service when I saw this patient. So the impression of this CT scan was a bilateral automastoiditis with probable cholesteatoma formation and coalescence on the right with mild bilateral ethmoid and maxillary mucosal sinus disease. So this patient was actually for OR, so he underwent a canal down mastoidectomy with a tympanoplasty and meatoplasty on the right side. The specimen we got was sent to pathology, which came back as a cholesteatoma on the right side. And we gave this patient antibiotics, and yeah, he improved well with the not hearing wise, unfortunately, but the we were able to control the just the infection. So I guess the final diagnosis we had here was chronic mastoiditis secondary to chronic otitis media on the right side with a cholesteatoma. And for the left side, we weren't sure what to make of it really. So we just went back to the patient again after the OR because we were still so like, what is going on this left side? And then it turns out he also had like similar symptoms on his left side, like many years back, with just like discharge. And like, so we assumed we also had like a chronic otitis media on his left side as well, but we never really found out like the underlying reason why he was having so many ear infections. But yeah, uh, what I learned from this is that like for his hearing loss, we can't really do much. And the goal really is to just control the source of infection, which was just like sitting in there. So we took that all out. And yeah, it was basically source control. Yeah.
Wow, what a case! So it wasn't. There's no unifying sort of diagnosis. Well, there are infections both sides, but there is a cholesteatoma on one side. So what a journey, Aaron and Jas. That's incredible. I pretty much have this schema for hearing loss, which I kind of had to exhaust for this case, but very difficult case, definitely very entertaining. And unfortunate for the patient that he couldn't regain his hearing loss, but I think I've learned so much it will impact any patient down the road that comes to me with hearing loss. So really appreciate you bringing this case here on at 8 to 9 p.m. EST, 5 to 6 p.m. PST. Hope you were entertained there, Jas.
Sorry, I couldn't like find my unmute button. You know how Ravi were saying before the VMR that like it's an 8 p.m. discussion and I'm very tired and it's like, you know, working. I'm not tired anymore. I don't know how I'm gonna fall asleep after this. Like I'm like on pure adrenaline right now. Aaron, this was like such a great case. I learned so much, and there's so much that I have to read into now after this. So but Robbie, I'm glad I didn't have to do this solo, and it was you were a great partner to co-discuss with. Thank you everyone for bearing with us. Sarah, I can't wait to hear your teaching points.
You too, Jas. Thanks for coming on tonight to discuss this very difficult case, but very educational case. All right, over to you, Sarah.
All right. We started off by talking about an approach to hearing loss and saying that it should cover acuity of the disease, time course, important risk factors, including age, loud noises or occupation, as well as med exposure, bilateral or unilateral hearing loss, and type of hearing loss, whether that's conductive, sensorineural, or mixed. And then in older patients, sensorineural is the most prevalent cause, while younger patients may have more likely conductive hearing loss. Bilateral hearing loss may indicate a more systemic process than unilateral, so assessing for associated neurologic symptoms like vertigo or facial weakness can help localize if you suspect that it's one-sided or central. And then possible localizations can include the outer ear, which could be a foreign body, middle ear, which could be infection or complications of an infection, including extension or osteomyelitis, and then inner ear, including neurologic causes like labyrinthitis, infarct, malignancies, nerve compression, or infections of the CNS. And then if a presentation is chronic, it may lead us away from infarct and towards malignancy, like a compressive or infiltrative process, chronic infections like syphilis or Lyme. And then acoustic neuroma is one tumor that can result in a time course of hearing loss that's more chronic. And for an acute progressive time course, medications, acute infections, infarct, or progressions of chronic infections like TB could be pointed to. And then with somebody who has extensive treatment for an infection like TB, interrogation of the med list for potentially ototoxic drugs should be done. Additionally, the age of the patient in this case might have predisposed them to autoimmune causes. And we talked about vasculitis, including GPA. A hypothesis-driven physical exam is very important for figuring out what is wrong in the case of hearing loss, including doing the Weber and RIN tests, as well as cranial nerve exams and audiometry. Specific autoimmune conditions can predispose you to recurrent ear infections. IgA deficiency is one that we pointed out. And then sifting out relevant or coincidental past medical history can be important for clarifying the presenting syndrome. For example, the TB treatment occurring many years prior may decrease the risk for drug-related ototoxicity. And then we also talked about the RIN test not being able to distinguish between normal or sensorineural hearing loss. And it would be very rare for a cholesteatoma to be bilateral. So that is our teaching points for tonight.
Great job, Sarah. Thank you for putting all those wonderful points together and summarizing them wonderfully. Thank you, Jas, again for co-discussing, and Aaron, fantastic case, absolutely stunner, and a great review for hearing loss. I'll be definitely mulling over my schema that I shared in the chat. Have a great night, everybody. See you tomorrow. Bye.